Hello, everybody, and welcome to another episode of In Conversation Live. In fact, it's very nearly our 100th episode of In Conversation Live. And this evening, we've got a super guest, Professor Sharon Peacock, who is Professor of Public Health and Microbiology in the Department of Medicine in Cambridge and Executive Director of the COVID-19 Genomics consortium. We'll be talking about the COG-UK consortium. She's also non-executive director at Cambridge University Hospitals, that's the Addenbrooke's Hospital, and she's published over 500 peer-reviewed papers, raised £60 million in research as principal investigator, and trained numerous scientists in the UK and elsewhere. She's a fellow of the Royal College of Physicians, Royal College of Pathologists, and the Academy of Medical Sciences, as well as the American Academy of Microbiology, and an elected member of the European Molecular Biology Organization, or EMBO. And in 2015, Sharon received the CBE for services in medical microbiology. Wow, that is a pretty good CV, Sharon. That is an impactful CV. Okay, I thought, I said to you before, this is a bit like Desert Island Discs without the discs. So let's start with a little bit of background, because you've got an unusual background, haven't you? You kind of fought your way through things. So just tell us about your mum and your dad and how you eventually got into Southampton University, et cetera, et cetera. Let's hear it.
Okay, well, I'll give you the short version. And what I would say is the more you talk with people, the more you realize that your story isn't particularly unique. Lots of people have worked their way through adversity. But I was born to my mum and dad. My dad was a carpenter, actually, and my mum was a stay-at-home mum. And I think, well, I had a kind of fine childhood, although I didn't know anybody that had been to university. And in those days, and I'm relatively old now, in those days at school, there was something called the 11 plus. And the 11 plus was one of these big deciding exams that you either went to grammar school, which was a very small proportion of the population, or you went to secondary modern school, which was the majority of the population, or you went to a technical college. And I failed the 11 plus. And I guess that there were some people who kind of trained for it and did exams, practiced it, but my parents didn't really think about that. So I failed and I went to a secondary modern school. And I didn't do particularly well. I wasn't permitted to do GCSEs, or they were called O levels in those days, in science. I couldn't do chemistry or physics or maths or modern languages. So I didn't leave school at 16 with very much at all. I had a small number of GCSEs, and I went to work in a corner shop at 16. And I didn't have any career aspirations, actually. So I was working there, and there's a kind of notice board with jobs on there. And the dentist who worked next door to the shop, advertised for a dental nurse. So I applied and I got that, and I worked as a dental nurse, trained as a dental nurse, actually. Went to night school, learned how to do the kind of theory side of things. And after a couple of years of that, I thought, well, I do like teeth; they're really important. But actually, I want to be a bit more holistic in my thinking. I want to be a nurse, and struggled to get into nursing because I didn't have the qualifications. And they offered me something called an SEN training, which is like a 2-year training. But I wanted the state registered nursing, and so I managed to get into Brighton, trained as a nurse. And I don't know how other people kind of would relate to this, but I was on the ward for 6 months as a junior nurse, medical ward, and at this sort of eureka moment where I thought, actually, I want to be a doctor. How about that? And so I didn't have GCSEs, I didn't have A levels, and I was 6 months into my nursing training. I thought, doctors have a brilliant job. They talk to people, they find out their symptoms and their signs, they examine them, they do some tests, and then they try and put them back together again. I thought, oh, that's such a good job. But I didn't have a place at university, and I didn't have the A levels, and so, but that was a really defining moment for me. So to cut a very long story short, I qualified as a nurse. I specialised in end of life care. Went to evening classes to get O levels and a technical college to get A levels part time. And then finally, after several years of trying to beat doors down at university, I got a place as a medical student. That is another story, to tell you the truth, because it was quite difficult to get into university.
So actually tell us that a bit about how you persuaded them to give you an interview. Let me interrupt and say, by the way, we will take questions. If you'd like to ask Sharon a question, just type them in, and I'll try and read them out. So medical school, how did you get into it?
Well, I didn't know anything about medical school. I had never heard at that point of Oxbridge. I didn't know what it meant. I didn't know anybody that had gone to university. So I went through kind of the UCAS system, and I went through clearing 2 years running, and I applied for 5 medical schools, mostly in London, but Southampton as well. And I was looking for a mature student program, because by then I was 23, and I was just about to get married, and there was a course in St Mary's in London or Southampton, and I thought that would be ideal for me, because I think at 23, it'd be good to have mature student friends, and I got rejections, and so I rang up Southampton one day. It was August actually, and the start was September, and I rang them up and said, "Look, you've turned me down twice, but I really would like you to see me and just meet me." So I was sort of fortunate, because the admissions tutor, David Bolton, he's an emeritus biochemist. He saw me, and he gave me a place. I think somebody must have dropped out, quite frankly, because I was in medical school within a month. It was a bit of a kind of whirlwind, but they said, "Yeah, okay, we're gonna give you a place," and I'm grateful for that opportunity, because that was another defining moment, actually, when I got to university. That was amazing,
Yeah, and that eureka moment, well, 2 eureka moments. I mean, analysing back now, what was it? Did it come out of the blue, and then how did your parents respond to this? They thought you must be mad, did they?
Well, I think so. Yeah. I mean, knowing that I wanted to do medical school, I mean, people say that you make decisions through, your head, your heart, your gut, or your wallet, and I think this was a real kind of heart thing. I wanted to do something meaningful, and I kind of loved what they did. So it was a surprise to me, and I had no idea how I was going to do it. And I told my parents sort of rather tentatively, and they said, "Well, why do you want to leave nursing? Nursing's a really good profession. That's a really good thing to do." And I think they were worried that I might get hugely disappointed, that I wouldn't make it. And especially when I got rejected twice, I think they were thinking, well, you could just make yourself jolly unhappy when you've got a perfectly good job doing what you're doing. And I did enjoy end of life care. I found it hugely rewarding. And so they were really quite anxious about it. And by that time, I had a kind of long-term partner who just used to placate me by making me meals and say, "It'll be okay in the end." And so that was, that's how it went, really. I think it was blind faith, it's blind faith, really. And then when I went to university, it was another big shock, because I was mixing with people really from a kind of different background and mix, really. So that was also a bit of an interesting wake-up call. And I just decided to work my socks off once I got there.
Yeah. Because it's a bit slightly crazy place, Southampton, isn't it? The student union there's quite a bit of drinking culture. I bet there was in those days.
Well, I had no time I had no time. I had no intention to drink, actually. Right. So I hope some of my friends aren't watching say, "Oh, that isn't quite true." Generally, because I was living in Southampton, my husband was in Brighton. I'd work really hard during the week and then go home at the weekend and spend time with him. So. And it's quite interesting. I lived in a kind of legalized squat in Southampton because I didn't have any money, and the university were buying up all these houses that they were eventually going to flatten to build new accommodation. So they let students rent it for like £4 a week or something. And so we didn't have heating. We didn't really have hot running water. But that was also, I think, analysing it, I kind of like putting myself into sort of weigh out sort of situations and just seeing what it feels like. So that was good fun. You know, you'd swap furniture between different houses. It was called Prangle, and it's association, so people helped each other out. So my version of Southampton and other people's version of Southampton might be slightly different. I certainly wasn't in the drinking culture. I was kind of, you know, trying to make ends meet and living in this.
You're in the working culture, not the drinking culture.
Yeah. I stayed in the library till 10 at night because actually it's the warmest place to be.
I'm afraid that's what people may have to do in the future with the fuel crisis.
Yeah.
So why then microbiology? Why? I'm a urologist, as we were discussing. So what was it that led you into microbiology, and that put you in a great position in the COVID pandemic? We'll come on to talk about. But in the early days, why microbiology?
Well, it wasn't early days, really. I wasn't really a microbiologist in the making from the very outset. I wasn't sure what I wanted to do. I liked medicine, which is why I did my MRCP, and I thought I wanted to be a cardiologist, actually. So I applied for a job in Oxford. I was working in Brighton at the time, having been to the Whittington and various other places, and got my MRCP, and I applied to Oxford to get a registrar position in cardiology and respiratory medicine. And they, I think, had already identified somebody who they were really keen on. But they actually said to me, why don't you come and work here? You know, you can backfill some SHO positions, senior house office positions, and come and see if you like it in Oxford. And I sort of remember going back to my consultant back in Brighton, Douglas Chamberlain, who was an incredible cardiologist. And I said, do you know what? They've offered me this sort of half-baked offer of I can backfill the job of the guy that's got the job I applied for. What do you think? And Professor Leddingham rang me up and said, are you going to come? And so I must have been so stupid and naive. I went to my consultant. I said, this guy, Professor Leddingham, rang me up twice, actually wants me to come. You know, I don't really know. He said, I think you better go. Because, of course, you know, an author of the Oxford Textbook of Medicine. So I went. And it was there, really. I was doing general medicine, lots of stuff. And I worked with Professor Weatherall and Worrell. That was an amazing experience. But it was there, really, that I got into contact with the global health side, with Nick White, with Nick Day, with Derek Crook, with Tim Pito. And they said, you know, microbiology and infectious disease is really interesting. Why don't you kind of come and see what it's like? And that's, and again, it's like things happen. I don't think I've ever made a decision about my career in my life. I sort of just think, well, that sounds quite interesting. I sound very undecisive. Things have happened in a way that I never planned. So I went and did microbiology in Oxford. I became a consultant at the John Radcliffe Hospital, and for part of the time I was running the laboratory there. By the time I'd got my MRC path.
And then running the laboratory, is that when you got into the sort of biochemistry and the DNA sequencing and so on? Or was that later?
No. I mean, being Oxford, people were keen that I did a kind of research. So I got a Wellcome Fellowship and was doing cellular biology, looking at the interaction between the pathogen Staphylococcus aureus and actually human endothelial cells, and looking at entry pathways, etc. But after 5 years of running my research group, I decided to go to Thailand and worked in the Wellcome unit there in Bangkok for 7 years, and started to study some really, really fascinating diseases of, you know, really the rural poor, melioidosis, leptospirosis, rickettsial infections. And when I came back with I had three children by then, by the way. So I went to Thailand with a 6-month-old and 2 6-year-olds. And when I came back, I thought, I can't bring my study back of these diseases. I'm going to have to reinvent myself here. And it was at that point that I thought, well, what's really kind of on the cusp of being something really quite important? And it was genomics. Genome sequencing was really coming to the fore. You could have a benchtop sequencer in your lab all of a sudden, just at that point. And I thought, oh, that sounds really interesting. So I started thinking about sequencing, and I didn't know anything about sequencing really, but that's when I kind of reinvented myself again in terms of what I did.
Was that roughly when David Cameron came up with the sort of human genome sequencing, or a little bit before that?
It was a bit before that. So I came back to Cambridge. So I was offered a chair in Cambridge in 2009. And it was then that I started to work with companies like Oxford Nanopore Technology, Illumina. And my PhD students were some of the kind of early, there are many people doing this, but some of the early investigators looking at Oxford Nanopore Technology and having the company to develop it. That's how the instrument was developed, by trial and error, really, from people using it. And I worked very closely with Illumina. And it was then that I had already started to publish in Genomics, looking at the role of genomics in outbreak investigation before Sally Davis put together a working group to think about the 100,000 Genome Project. And there were 3 working groups, one on cancer, one on rare diseases, and one on pathogens. And I chaired the pathogen group, saying, what are we going to be doing sequencing pathogens? Where can we really make a difference? So we had our recommendations, and David Cameron announced the 100,000 Genome Project. And, pathogen genomes didn't quite fit with human genomes because they're kind of tiny, and you don't need a great big machine to do that sequencing. Logistically, it doesn't quite fit. And at that time, I don't think people really realized how powerful sequencing pathogen genomes actually was. And so I think that for some time, there was kind of a dominance of sequencing for human conditions. And of course, there's been amazing strides in that area, in those areas of rare diseases of childhood, for example, and cancer. But pathogen genomes had to do a bit of catching up in the last 2 or 3 years.
Sharon, not all of our viewers will be medical, so just in simplistic terms, explain sequencing and pathogen sequencing. What you're looking is the base chain pattern of the pathogen in general, virus or bacteria, I guess. Is that right?
Yeah, absolutely. So you're looking at the genetic code. So you're looking at the bases of the genetic code, and you're going along the DNA, or in the question of COVID, we might come on to that, but that's an RNA virus. But you're kind of working out what the DNA code is. And it's like a kind of a list of letters. And the human genome is very, very stable. You don't tend to get mutations in that, because that can often lead to disease, or to that person not surviving if a mutation occurs in the kind of pre-embryo or embryo stage. For pathogen genomes, they change very quickly. So what you're doing is you're looking at the genome to look for basically a typo. So human genomes don't have typos very often. Pathogen genomes can have them really quite often. And that is how pathogens evolve. It's Darwinian evolution. And that is what leads to the changes that's what's underpinned the whole evolution of the species. And that's what underpins the evolution of bacteria and viruses, so that they can change their characteristics, they can become resistant to drugs, etc. So it's like looking at that change, and then you're going to compare that genome, for example, to a reference genome to see how they differ, and therefore what that mutation actually means in terms of function. Mm-hmm. So it's basically checking out the kind of the genetic code of that basically encodes everything. So the DNA encodes for the proteins, and the proteins build the structures of our bodies.
Well, there's one comment from David Lewis, and any more questions, welcome. David says, not really a question, but interesting story. He knows so many people who are leaders in their professions whose backgrounds bear close similarities to yours, which is pretty much what you said. But let's stick with sequencing, and what's made you famous, Sharon. Your name now resonates because of this. Is basically the pandemic and COVID. And we were talking before this about the COG group that you constructed and put together, and I think people would be really interested to hear about that. And I mean, it was kind of a stroke of luck, wasn't it, that COVID came along for you? I mean, bad luck for everybody else, but for you.
Yeah, well, I think that it's a question of how you define luck, actually, and I think it's hugely bad luck that it happened at all. But when it was clear that we were going into a pandemic, the question, and I think this was another defining moment for me, there have been several in my life, and a defining moment for me was to say, do we need to start sequencing this virus, because it's inevitable that it's going to change, and it's going to change its genome, and that's going to change the way it interacts with us. And I was chatting to Sir Patrick Vallance, our government chief science advisor, who is incredibly, I mean, I'm in absolute awe of Patrick, and we were talking to, absolutely, we need to have sequencing of this virus. And there wasn't the capability across the country to sequence the virus at any kind of volume. However, you know, we had very deep roots in terms of our expertise across the country. We knew how to sequence. We had sequencing instruments across the country. We had a kind of this mega database for genomes called CLIMB, which has already been funded by the MRC. And people knew each other quite well. So he said, right, sort of go and sort it out. We'll look to fund it. And so you have to have the confidence to do something like that. So I rang up five mates and said, I just dropped them an email. I said, can you call me this afternoon? I've got something I want to talk to you about. And you know, we're going to have to sequence this virus. Absolutely. So I called 20 people, colleagues, together at the Welcome mid-March and said, okay, we need to set up a sequencing capability for the country. And the 4 public health agencies were represented in that. It was really key that we had that, because we hadn't shared genomes across the different nations of the UK before. And so we had to come up in that day with a blueprint for how to sequence SARS-CoV-2 at a volume across the country. And that's exactly what we did. We came up with a blueprint. We wrote an application over a course of that weekend. And within 2 weeks, Patrick and Chris Whitty had given us £14.5 million from what's called the COVID-19 Fighting Fund. And that allowed us to set up 16 regional sequencing hubs, sequencing at the Wellcome Sanger Institute, which they also funded in kind, and 4 public health agencies. So that was just the beginning, actually, because we had to set up sequencing and match that to the testing, because we used the kind of waste from PCR tests. We got that, and we converted that into DNA and sequenced that. So we had to start from scratch. But by the beginning of April, we'd already sequenced, you know, several hundred genomes, and we just worked as a consortium. That's 600 people, mostly of volunteers, that helped set that up, and we had a mission. That's what we did.
Well, I'm going to come on to a couple of really technical questions from Andrew McCutcheon. Thanks, Andrew, for those. But just before I do, I'm going to read them out in a minute. Just again for the audience, just go through kind of in a nutshell what's happened with sequencing in terms what happened with the virus. The virus has been changing, hasn't it?
Yeah, it has.
And you know, for Alpha to Delta and Omicron,
yes.
etc.
Yeah.
Just in a nutshell, describe what's happened and a little bit of an explanation around that.
Well, we were sequencing increasing volumes to really try to understand what we're passing the genome data on to the public health agencies, and they would join the genome data with the person information, whether they'd been vaccinated, whether they were part of an outbreak, and so on. So the magic really happened in the public health agencies. And so we were kind of on it was on the watch list for us until Alpha emerged. And, you know, at that time, it was clear that there were several explanations for the kind of explosion of cases in Kent and parts of London. Either they'd been a very large super spreading event, we knew that could happen, or there was something different about the virus. And it was really when the academics and the public health agencies came together to bring together the epidemiological information of rapid expansion together with the genome, when there was a realization that this genome was really quite different from previous, the kind of circulating, what we call the world type or Wuhan strain. And there was a lot of changes in what's called the spike protein gene. That's the part of the virus that interacts with your cells and is vital to get into your body in the first place. And that's what our immune system is largely targeted towards. And so there was a realization that this looked different, but the proof was really in then tracking whether it was more transmissible, whether it could evade your immune system. That was all laboratory experiments, and whether it was cause more severe disease or not. So Alpha was kind of the wake-up call, I think, and that really kind of blew up around Christmas. And I remember telling my colleagues in the consortium, we're going to wind down sequencing a bit over Christmas to give you a break. And that was on the 17th of December. And by by kind of just before Christmas, I was writing to everybody saying, can you all come back? Because we've got to sequence, this virus a lot and really get the sequence and compare it with the patient outcomes and with immune evasion and so on. So that really shifted the dial. And then we were really watching very carefully for what happened next. And then, of course, we had Delta. And I think that we've got the Omicron variant at the moment. And what we're seeing at the moment is that Omicron dominates the world. So what happens when one of these variants arise, they're better than the previous version. And they're better in terms of being more transmissible in case of Alpha, or more transmissible and being able to evade your immune system more in the case of Delta. And with Omicron, fortunately, it causes less severe disease, but it spreads very quickly and it has immune evasion properties. So what's happening at the moment is that Omicron is just like across the world. So the latest WHO reckoning, the month between July and August, nearly everything that was submitted to GISAID, which is kind of like the international genome database, was Omicron. But we're kind of seeing tweaks in Omicron. So we have different subversions or subvariants of those, and something called BA.5 is the thing that's predominating in the world. So at the moment, it's kind of like holding in Omicron with sort of minor drift of Omicron, perhaps trying to find, some advantage, biological advantage. It's kind of like through evolution, it's chance. And the key is really to wait to see whether anything else emerges in the future that would have even more transmissible or evasive properties. So that's where we are at the moment. But it has been an incremental steps of new variants coming along, which outpaced the previous variant, and then through international travel spread around the world very quickly.
That's a lovely, clear explanation. So, okay, Andrew McCutcheon says most SARS-CoV-2 vaccines express only spike antigen, and we've been told that the spikes change with recent variants, but to what extent have other components, such as the nucleocapsid envelope and other elements change? Have they changed more or less than the spike?
Yeah, okay, thank you for that question. Well, I would, before I answer that directly, what I would say is that that the immune response is largely to the spike protein, and as a result of that, the vaccines have been directed to spike. And they have been incredibly effective, actually. They've saved millions and millions of lives, and they've done that through making disease generally far less serious. The genetic changes in the spike are really well studied and highly characterized. The genetic changes in the rest of the genome are less understood, actually, overall. And the contribution of each of those, because there's kind of multiple possible variations of mutations that can occur together. There's less understanding of what they do compared with mutations in the spike protein. The kind of the nirvana that kind of would be to actually have a vaccine that actually protected you from the entire virus from nucleocapsid. To date, efforts to do that have not provided a vaccine that is as efficacious as those against spike, but kind of the dream would be to have something that was actually, the dream would be to have a vaccine that prevented transmission. That would be a game changer, and it could be that we need vaccines that kind of really affect the antibodies in our nose and throat for that to be the case. Or a vaccine that was kind of like pan-coronavirus. So, we no longer got colds. But at the moment, the position that we're in is that we have vaccines against spike. And the current push is towards those that kind of like, so a bivalent vaccine, for example, that's going to be rolled out in the UK. And that's against not different parts of the virus, but different viruses. So the Wuhan, the original wild type, and Omicron. And the problem with developing new vaccines is that there's such a long relative lead time, that by the time a new variant comes along, say, for example, BA.5, then you then have to develop your vaccine all over again. But it's going to be interesting to see how these bivalent vaccines, that they're being rolled out, and they do appear to have a kind of marginal increase in immune protection for people. So I think that's a very long way of saying that we've still got a long way to go to understand the virus actually, and to understand how we then develop the best possible vaccines, accepting that vaccines have been developed at kind of lightning speed compared to pre-pandemic.
Yeah, and obviously this is going to be speculation, but do you think we're going to see another variant emerging? It's impossible, but do you think Omicron now is as you say, 95% of cases or more, and maybe it's sort of reaching a stable state now? Hopefully, what do you think?
I feel more optimistic that we're reaching a stable state now than I did, say a year ago, because we were constantly, well, not constantly, we were regularly seeing new variants coming along. We haven't seen anything. But, it's so difficult to be categorical about anything. And if I've learned anything in this last 2 years, it's to not be categorical about anything, because you'll get it wrong. So what I would say is I'm more optimistic that Omicron will stick, but the key for me is to not make any sweeping assumptions that changes practice. So we do need to keep sequencing the virus. We do need to keep watching the epidemiology, because even if you start to see a sudden expansion in cases, or you start to see an expansion in severity of cases, then that's when you're going to go at it with your sequencing instruments. So I don't think we can ever afford to be complacent, but that's where good public health surveillance really comes in, and excellent public health doctors and organisations to watch what's happening.
Okay, I'm going to move away from COVID in a minute. I just a second question from Andrew McCutcheon, which is about which part of the SARS-CoV-2 virus is the most potent inducer of long-term T immunity? Is it the nucleocapsid, the spike, the envelope, or something else?
Yeah.
Can you answer that one?
Yeah, well, I can try. I have to say I'm not an immunologist, but my understanding is that what we're doing with our vaccines against the spike actually does give long-term T cell immunology, T cell memories, but I would say that as a non-immunologist, I wouldn't stick my neck out and say that I can categorically reply to that answer. So if you're interested, I'll certainly look it up and get back to you.
Okay.
But I have to say I'm not an oracle on everything immunological and.
Well, there's kind of one question from me. I've been in close contact with loads of people who've had COVID, but I've never caught it. Didn't you say your husband's the same? He's never caught it.
He has, yeah.
Yeah,
absolutely.
So why are some people immune?
Well, I don't think that's fully understood.
No.
It's true that some people don't seem to have it. So it was actually only March when I got COVID, and I was at a wedding, and my husband was with me. He was sitting next to me. We were on the dance floor all night, and myself and several other people got COVID, and he didn't. And we've had people in the house. Our children have had COVID, and but there must be something there. And this it's not the same, but it has parallels in that sort of thinking around HIV. So many years ago there were people that appeared to be to have immunity against HIV as well. And some of the work done by Sarah Rowland-Jones and others looking at people who appeared to not contract HIV, I think is really interesting. So this comes down, I guess, to genetic variability in our immune systems, meaning that and we know that infectious diseases, our genetic composition has a huge impact on whether we will develop infectious diseases or not.
Yeah, that's interesting. Okay, so let's move away from COVID. I bet there'll be a lot more questions about it, but I think that, there's so many other elements of your career that are interesting. There's a nice question from David Cochran, which goes back to getting into medical school. And I know you're quite passionate about giving people opportunities, people from backgrounds that you wouldn't expect necessarily to go into professions, giving them the chance. So he says, with medical school applications being greater than places, I think there are 30,000 applicants for 7,500 places, if I remember, something like that. How should applicants be sifted? He said, I too failed the 11+, but this weekend I'm attending my 45th medical school reunion. and he thinks he probably wouldn't get a place now if he if he applied. But I mean, that's quite. I know you probably are involved in selecting medical students, but also just can I have your thoughts on giving other people opportunities? I know you're passionate about that.
Yeah, well, I think that it's not just medical school, it's everyone around you giving people opportunities. And often it's something you say or something you do, which is quite small to you, but it's quite large to other people. So David Wilson giving me a place was something he did every day to people, but it changed my life. So I think it's not just medical school, which I'll come back to, but every walk of life, trying to give people around you opportunities. So I spend quite a lot of my time mentoring people and supporting them, because I think that's important. In terms of medical schools, I don't think there's a simple answer, because if there are lots of people wanting the place and only a few places, some people are going to lose out. So I do believe that increasing diversity so that doctors reflect the people, reflect their patients is really important. So diversity in terms of ethnicity and social background is going to be really important. And so medical schools have to, I believe, take people from a wide range of backgrounds in order to reflect the patients that they're treating. But there are other initiatives too. So, for example, there's something called Into Science, which Colby Minari is the chief CEO, which I'm peripherally involved in, which actually says, well, people from disadvantaged backgrounds can actually go and do research in people's laboratories, etc., and tries to give people a lift up. Every small thing we can do actually to help, provides a kind of, I suppose, a patchwork of help to help people on their way, because there isn't I don't think it's a single fix. But the other thing is to have role models that have fought their way through, so that other people think, well, actually, I'm going to learn by being, by that no, and I'm going to try again. So trying to encourage people to chase their dreams and have role models that look like them, actually, or looked like them sort of some years ago when they were younger. So I think that each of us can only do our best to serve the people around us and help them have an opportunity. But I think it's reminding yourself every day, what have I done today to help with equality and diversity, or helping other people? And that's something I try and remind myself. I sort of sometimes feel I should have something on my fridge, so that every time I go to it, and I do go to my fridge quite a lot, when I'm opening the door, I sort of see something that says, right, just think about your attitude to this, because if everyone did that, then we'd probably change things quite a lot, I think.
Yeah. It's the way you treat other people, I think, isn't it?
Yeah.
So John Rye, thank you, John, for your question. So much of what you shared, Sharon, is about building and keeping community within the medical community. How can this be encouraged, do you think? Because I think there is a bit of disillusionment and dismay, isn't there? Particularly the junior doctors are sort of gearing themselves up, possibly to go on strike. So what are your thoughts about medical community?
Yeah. Well, I can tell you what worked in COG-UK, and that was a community of 600 people. What helped for us was we had a common purpose, and we talked about that a lot. The common purpose was to provide genome sequences to public health agencies for the nation, and that really drove us. But we talked about it quite a lot, actually, and we talked about team building, and we treated people fairly. And as a kind of as the director of that, my sense was, I don't want anything myself. You can have all your authorships. I'm not going to be on any of the papers, etc., etc. So the usual currency of science, I didn't step into. So we built a community in COG-UK, and we treated everyone equally. And so, a research assistant would be giving a presentation, for example, or writing a paper. But how do you do it in medicine? I think that common purpose is still important. So people that go into medicine, when I see young medical students, they are very idealistic. They want to help people, and it's keeping that alive when the NHS, we might talk about this in a minute, but the NHS is coming into a very difficult period, and building teams. I think having leaders, having people that are seen to be treating other people fairly, calling people out, calling people out when they're creating a kind of radioactive environment. And we all know situations like that where people are not called out, calling people out and saying, no, this is the values and the cultures that we want. But yeah, I think that, you know, the NHS is in quite a difficult place at the moment.
Let's come on to that in a minute, because I want to talk about your role on the board of the Addenbrooke's Hospital, Cambridge University Hospital. But this is a question, you're going to love this question, I bet. So Jeanette Dye, thank you, Jeanette, says, is there any advice about MRSA, i.e. how to get rid of it when you've had it for years? My daughter's had it for 18 years. She had operations to remove it years ago, but it's still with her. How can MRSA be removed? Now, I know you're putting together another group, aren't you, to study this? So tell us about your about that MRSA. Staphylococcus aureus vision multi-resistant.
Yeah, that's right. So methicillin resistant Staphylococcus aureus. So just for other listeners, Staphylococcus aureus is a kind of gram-positive bacterium that lives in our noses. That's its kind of natural niche. And around 40% of us, 30 to 40% of us always carry it there. Whenever you kind of put a swab up and have a look, then it's there. And about 20% of people never seem to carry it at all. And then the rest are kind of intermittent carriers. So you sometimes find it and sometimes not. And when it's actually living on you, it doesn't matter at all, really. It's just part of your flora. But it's one of the major causes of nosocomial infection. So if you have an operation and this organism gets in there, it can cause nasty infections. And that's the key thing. It's a kind of common cause of infections. It can cause infections in your bones, your joints, your heart, etc. And it can kind of cause boils and so on. Now, methicillin resistance. When antibiotics were developed, then we use something called flucloxacillin, or that's that kind of drug for treating Staphylococcus aureus infections. And almost as soon as we devised how to treat it, the organism had developed something called methicillin resistance, so it's resistant to methicillin. Now, if you carry that, and around 1% of all the population carry it, so if you're on an underground train and there's 100 people on there, one of those is going to be carrying MRSA. Again, it doesn't matter. But when it does matter is when it causes an infection, because the drugs that you'd have for your infection that the doctors would prescribe are different if it's methicillin resistant versus not methicillin resistant. And the drugs against methicillin resistance are not quite as effective as those against the sort of sensitive, cousins. So in terms of getting rid of carriage, then that can be quite challenging, but topical antibiotics, it depends what the antibiotic resistance profile is of the MRSA. Getting rid of carriage means seeing what it's susceptible to, and then some treatment can be put up the nose. So, for example, healthcare workers who'll carry MRSA, and they do sometimes because MRSA is in the hospitals and they can breathe it in sort of from the bed sheets or from patients and become colonized. We decolonize staff, so they're not MRSA carriers, and that's with kind of stuff up the nose for 5 days. So it depends on the resistance profile, but that can be something that can be done. If it gets into bones and joints, it can be quite difficult to clear, and then that can be quite a protracted medical issue. So I obviously don't know the details of it, but particularly if prosthetic material is involved, getting rid of actually the susceptible versions or the resistant versions can be really quite challenging. So I'm sorry to hear if your daughter is affected like that.
Tell us a bit about your carriage study. It's called the carriage study, isn't it?
Yeah, it is. Yeah, carriage. So one of the things that really interests me is that why is it that 20% of people get lucky and they never carry this and they don't have Staph aureus sepsis? So the rate of them having infection from this organism is right down. And so we're doing a study where we're looking at and it has to be really, it's not the pathogen isn't working this out, it's the human that's working this out. So we're doing a study of a very large number of people, and we are looking at their human genomes, and we're looking at a whole raft of what we call phenotypic traits, so their blood results and their biochemical results and so on, to see whether we can spot the genetic difference in people who carry. So we're recruiting a very large number of people, some of whom are carriers and some of whom are non-carriers. So we work out by sending swabs through the post, actually, which works quite well, they pop this up their nose, they send it back to us, and we work out if they're carriers or not carriers. And then we look at their human genomes. We're kind of partway through this study. But what we hope to do by looking at the genomes is to say the reason that this group of people are not carriers and this group of people are is because of gene X or genes X. And that kind of provides a new way of thinking about how to try and get rid of carriage. Is there a vaccine we could produce, or is there a new medicine we can produce? So that's we're still a few years away from that, but understanding the kind of the biology of carriage, and that, as I say, I think it's almost certainly within our genes, could be really helpful in understanding how then some people are non-carriers and how they kind of boot presumably they get exposed to it, but it gets booted out.
Okay, we're going to turn to your job as non-executive director at Cambridge, Addenbrooke's University Hospital. But the one more question, well, a comment question first from M. Kearley. Thank you. Thank you for your interesting thoughts. Just wondering what you think about the fact that so many medical students want to leave their careers in the UK and go to other countries like Australia. What can we do to keep them in the NHS? It's a good question, a very important question. It costs about £250,000 to train a doctor, and then to find they'll disappear to another country and work there is disappointing, to say the least. What do you think?
Well, if there is a mass exodus of anybody, the first thing to do is to gather information about why that's happening. Exit interviews are going to be really key. Perhaps that's been done, and apologies if I'm ignorant on that, but exit interviews are really important. That gives you the direction of how you fix that. Is it the hours? Is it the COVID exhaustion? Is it the pay? And then you have to try and fix it. So you're right, that there is an exodus of doctors, and we don't have enough nurses either at the moment. And so understanding why people leave and understanding what it would take to fix it so that we can train our own and keep our own staff. Because people go into it with the right intentions and for the right reasons. And it's a huge pity if we're losing that incredible resource that we've got. So again, it's not simple, but it's likely to include investigation, evidence, and money.
Yeah. Well, as a scientific approach to the problem. Yeah. So let's go on to non-executive director, and we were talking before about how more clinicians ought to get involved in hospital and healthcare management, because actually that might provide more of an incentive for the sort of to try and break down the barriers between management and the clinical staff. What are your thoughts about that? Just tell us a bit about your experiences. Cambridge is an enormous hospital, isn't it? It's got a budget of probably about £1 billion or something like that.
So I think that management gives people new opportunities. So I kind of never really stop doing something different. So I've done all sorts of things in my career. I've also done a history degree and all sorts of other stuff. And for me, it's like I have no intention of retiring. I love that website called Retirement Postponed. It gives you lots of ideas about non-exec positions and trustee positions, etc. I kind of love doing something different. And my if other people listening like doing that, going into a management position, if you don't like what you see around you, then the way to change it is to actually go and change it yourself. So I do encourage people to go and have a conversation to see there's loads of different roles in management you can do. In relation to medicine, and they're largely, except for the medical director, they're largely part-time. But I'm always rather curious about things, to tell you the truth, and I was curious about how hospitals ran and how businesses run. I knew nothing about boards and management and so on. So I actually decided to do a diploma, a 6-month distance learning course with the Financial Times on how to be a non-exec director. And again, it was kind of like this kind of heart thing or gut thing. I was thinking that'd be quite interesting. So there were kind of 5 modules on, board structure and risk management and audit and financial planning. And I thought, I'm going to go and immerse myself in that because that sounds really interesting. I just did it alongside my other jobs rather than doing it separately. And before I'd finished the course, I'd been approached to say, would I apply to be a non-exec director at Addenbrooke's Cambridge University Hospitals. And I was fortunate to be offered the position. And it was just at the beginning of Addenbrookes going into special measures, actually. So it's a very interesting period of time. And I have learned more about, well, just so many different things: risk, audit, quality, safety, finance. My learning curve was so steep in the first 2 or 3 years. And the great thing about being a non-exec director on a board or elsewhere in government, etc., is that it's a part-time role. You don't make the decisions; it's advisory only, and so it's helping, but in a very different way. And so I've been a non-exec director at Cambridge now for 7 years. I chair the Quality and Safety and Patient Experience Committee. I'm on the board, and I'm kind of part of the audit committee. And for people that are kind of curious about stuff, I think going into management or non-exec positions or even trustee positions, I think it's brilliant. I never have the same day twice, really, because I've always got something different or interesting to look at. And for me, the NHS has been a lifetime of commitment, but I've done it in different ways. You know, teeth, nursing, medicine, microbiology, non-exec director, and I never want to give that up. But it's all done in sort of different ways. So it can be quite refreshing to do something different, to learn something different like that. So that's what I do.
Are you worried about the way that the NHS is under such stress at the moment?
I'm hugely worried. I really can't remember a time when I was as worried about the NHS. And you know, this is something that everybody will know. It's in the public domain, but you know, the waiting lists are getting longer, and there's a shortage of both nurses and doctors. And, you know, we're at the end of a kind of, well, not at the end, actually, even of a very exhausting period of COVID, where people are, you know, their mental health has suffered and their physical health has suffered. And the kind of combination of that kind of tiredness, lack of staff, the salaries, and the cost of living, I think that there won't be anyone working in a hospital that feels much differently to me, in that I think that we're going into a difficult phase in the NHS, and also NHS have got to keep the lights on too. So, you know, the electricity bills are going to go up, etc., etc. So, you know, I don't know how you feel about the NHS, but I think it is a time to be concerned and to listen very carefully to what our politicians are telling us about how they're going to try and support the NHS going forward.
Got any solutions? I mean, Maggie Thatcher famously said, "I hear the problems, but I want some solutions." What would you change to improve the situation?
Well, a focus on reducing the waiting lists is going to be vital. I think a focus on the front door and the run through to a discharge is really vital, because in many hospitals there's huge front door demand, but not enough rear end discharge capabilities to social care. So I think social care demand kind of the GP aspect, and also the end sort of back end, where do you send people, has got to have attention. You've also got to pay attention to staffing numbers. So what's the staffing strategy? What's the people strategy for both, you know, nurses and doctors? So those are kind of, I suppose, 3 key areas really, 4 key areas really. So GP, social care, which relates to demand and flow, waiting lists, and staffing. And do you know what that comes down to? Tactical thinking, strategic planning, and money.
Yeah. I mean, and unfortunately, there are sort of individual cases. There was one in The Guardian, wasn't there, a little girl dying of sepsis with the parents being so desperately upset, and it wasn't clear actually whether it was a case that would have responded to different treatment. But highly publicized mistakes, I mean, you must be facing those in your committee that you chair at Cambridge. And how do you deal with medical accidents?
Well, there's kind of a really clear pathway that serious incidents go down, and as well as never events. So there's kind of, once something like that happens, then there's a reporting mechanism, investigation mechanism, and so on for those. So I get to see the never events. I get to see the kind of the incidents that lead to, mild, moderate, severe, or catastrophic outcomes. And so we in the healthcare profession, we have to accept that we are human and that we do make mistakes. And we can follow every procedure there is in the book. So, for example, the kind of the WHO type checklist for theatres and so on, so you don't end up doing the wrong side surgery, etc. But people do make mistakes, and if we make mistakes, then having honesty about that, and but in order to be honest, you have to feel that you're in an environment where you can speak up. So having the freedom, the ability to say something has gone wrong. So that things and that what that means is that you can't blame the individual for the error. You have to blame the system and the process. You have to look at what's gone wrong in the process. And if somebody's made an error because actually they weren't listening or they kind of ignored advice, that's one thing. And there's a mechanism to deal with people who've in that category. But generally, if somebody's made when I say an honest mistake, something that happened, but there was no misintention there, then we have to, as a group of people, think about that holistically rather than it's the fault of an individual, because otherwise nobody will come forward. And you see over and again, issues that come up in that it's due to kind of a collision of people not speaking honestly about what's happening. The kind of maternity, the Ockenden report, for example, on maternity in Shrewsbury and Telford, and we've seen that before. People not telling the truth. It's easy for me to say, it's hard to do. I'm sure people will be, at the other end of listening to me, thinking it's okay for her to say. That's really difficult to do, but that's the culture we surely have to try and work towards.
There's one of your predecessors on this In Conversation program is Professor Jane Somerville, quite a famous pediatric cardiologist. Her husband Walter Somerville was one of my teachers actually back at the Middlesex Age. But she's very keen on the idea of whistleblowing. If you see something going wrong, you better speak out about it. But I mean, what would your hospital board say if you had people whistleblowing about mistakes? Is that something that it would be regarded as good or disruptive?
Well, there are certainly people in the hospital that you can go to, freedom to speak up, and so we would encourage people to speak up if they've seen something. And every hospital has surely whistleblowers that go, and they can either go to the CQC or go to the hospital and say, I've seen something that isn't right. And as a non-exec director, I would absolutely take that seriously. And I believe that certainly Cambridge University hospitals would take very seriously that type of incident where somebody has said something isn't right here. And I think generally that, one would hope that hospitals would listen to whistleblowers. I mean, that's kind of fundamental principle of investigating whether what they're saying is true or not. So I would see in the hospital context that that whistleblowers should be listened to, and to work out if what they're saying is has the basis in poor practice, and that's how you can get things fixed by listening to people.
Maybe not going straight to the media might be one thing. No. Okay, we're running out of time. We've got just really a couple of minutes left, but there's a nice question from Aminul Schuster. He says, Sharon, how do you unwind from your role, especially during the busy stages of COVID? What were the strategies that you used? I think, probably quite a lot of us who during our careers have worked really hard. It's not always easy to unwind, is it? What are your thoughts about that?
Well, I've got two passions. I've got a gym membership. So I go to about 6 or 7 classes every week. So I do that, and I've got an allotment. It's a bit dry at the moment, has been dry until recently. So I grow onions and leeks and so on. So I go and dig. So I either dig or I pump weights.
Would you describe yourself as a driven person?
Based on that,
Yeah.
I think I probably am. I'm never still.
Yeah.
But you know what? If people said, are you ambitious? There's something quite different between drive and ambition. I think the word I'm looking for is curious. I'm not ambitious. I'm not kind of driven. I'm kind of curious about stuff, and I get kind of really interested in stuff. I wake up in the morning buzzing with stuff, ideas and so on. So, yeah, I'm an active, curious person.
I think that's a great way to finish the session. So don't go away. Just before I leave, I wanted to make an announcement about next Wednesday. I actually won't be there, but I'm going cycling across the Alps to raise money for the Urology Foundation. But my predecessor as president, Simon Wesley, will be interviewing Julia Gillard, ex-Prime Minister of Australia, no less. And that's in person at the RSM. So you can come along, listen to Simon ask Julia some questions, a bit like I've just asked Sharon, I bet, and you can ask some questions yourself. And there is a dinner afterwards. Everybody likes dinners at the RSM, where you'd have a chance to mingle with network with some of your guests. So do come along to that. And the week after that also is in person, in conversation. That's Baroness Sheila Hollins. And again, there's a dinner after that. So you're all very welcome. So thank you so much, Sharon. I really loved interviewing you. You're like such an easy person to interview.
It's a pleasure. It's an absolute pleasure.
I bet you're good at digging leaks as well. I can imagine you are.
Yeah, I'm probably going to eat some for tea in a minute. So.
Okay, well, thank you everybody for listening. Thank you, Sharon, and hopefully see you next week for Julia Gillard, or the week after for Sheila Hollins. Bye for now.